Hi, my name is Dr. Ken Rictor. I am a direct primary care physician from Scotland, Pennsylvania. As you can see from my shield up there, from my office logo, Scotland FMEC and direct primary care. And I want to spend some time today to talk to you about really what it's like to run a solo practice, what's really involved in taking a direct primary care office and to go from that. I'll give you a little bit of my background. I've been in family medicine now for 27 years in private practice, started right out of residency. And for the last 25 and a half years, I was a fee-for-service physician. So that was the structure that I had gone through residency and gone through my training and in early practice. That's really all I knew was the only way to really practice medicine. But for the last year and a half, I've adopted the direct primary care model, and I have found that to be a tremendously successful way of restoring what it was to be a family physician. So this is the way really to run a solo practice. I have a nurse practitioner that works for me part-time now, but for the most part it's just me in the shop. So we're going to go over a little bit of things. This is my title again, Scotland Family Medicine Direct Primary Care. And as I said, I adopted this model through a lot of frustrations that I had with our conventional system, and I will go through some of those a little bit later. But one of the first slides that you're going to see is a graph that shows really what makes up most of the workers today. As you'll see in a next diagram that I have, most of our insurance products today are purchased by the employer for the employee. What makes that difficult is that more and more of the employee's income is used to contribute toward that insurance premium. So what the employee is calling as, well, it's a free service, it really isn't when it's pulled out of their pay. But a lot of times they don't recognize it because they never see it. And what they don't know kind of won't hurt them. But if they really got to look down and say, what is this really costing me? It's quite a bit to be able to afford their care. So as premiums have gone up, so much has been the withdrawal from their pay, and as the graph shows, they haven't had a concomitant increase in their pay. So it's really been a level dose for what they've been paid, but more and more has been coming out. So there's less money to take home at the end of the day. And in essence, they're paying more for their health care, but really don't feel that. The next slide shows this. You've got 154 million Americans that are sponsored by insurance through their employer. And the rest is picked up by Medicare, Medicaid, and other type things. So still the employer is one of the big focus groups that still continues to contribute toward those fees and calls it a benefit for the patient. But as you and I know, if it's a true benefit only if you can really utilize it, and it's not going to take money out of the system. Most insurance plans today are still required for deductibles and co-pays, so it really isn't a free benefit, and you have to question how much of that's going to be a benefit. But that's the group of people that as a solo practice we're really going after, because that is the majority of Americans. The next slide is going to show you that what is the average amount of insurance that a family is paying today, and it's quite a huge amount. $16,000 a year is usually what it costs to be able to pay the premiums for family care coverage. That does not take into account the deductibles, it doesn't take into account the other out-of-pocket expenses. So we may be dealing in the aspects of some $19,000 to $20,000 that is contributing toward this huge $3 trillion medical bill that we have in the United States today. And the sad part of it, as the next slide will show you, is that the United States right now ranks 13th in quality care in all the world. So we rank 13th, and yet we cost more than 50% of the next industrialized country. So we are more expensive by 50% of the next country, and yet we rank 13th in quality care. So obviously it's not the amount of money that you spend into a healthcare system that increases that quality. And if you think the kind of illogic of this is, if I were to run a car dealership, and in this car dealership I said, I'm going to actually offer you a vehicle. Why don't you come out to my car dealership? And so there's a vehicle's on the lot. I said, the good thing is we're the most expensive car that you're going to buy. In fact, we're more expensive 50% than a Bentley, okay? And we'd like you to buy one of those cars. And actually we rank about 13th in quality of all the cars that are made in the United States. Obviously you wouldn't buy that product. But with health insurance, we do that every day. We do that a lot because we're told to do that. But most importantly, we do that because that's all we have known for decades. And we've fallen into this blinder type atmosphere that that's all I know, and I'm not really ready or knowledgeable to jump out of that trend. So when I started seeing a lot of these things happening with our patients, I really started recognizing there's got to be something a little bit different from what we're doing. The next graph is going to show you the amount of ER visits. Now, anybody in private practice will tell you, why are those ER visits so high? Most of them is because they can't get care elsewhere, or they can't get that urgent care, or they can't get that instant access response. So you've gone along and you've had a symptom complex that maybe's gone on for 7 days, but on that 7th day in that first hour, you suddenly become concerned about it, and now it becomes an urgent care issue. So I need to get that care. Where can I go to? Can I call my family doctor? Call the family doctor under fee-for-service. They say, gosh, we're booked up today. Next time we get you into next week. Well, that isn't going to work. Maybe go to the urgent care or emergency room, but you're taking yourself out of that comfort of your family physician. So you see ER visits have gone up over the years because there's just lack of care from the primary care standpoint. So when we talk about primary care, there are really 3 aspects to direct primary care and the whole concept. And it's built around increased patient quality, increased patient satisfaction, and decreased overall cost. And think about these for a bit. Increased patient quality, increased patient satisfaction, and the crazy thing is decreased cost. So how many products can we buy today that are going to give us a better product for less money? We're increasing patient quality because patients are having more one-to-one time with those doctors, increased patient satisfaction, and that they feel that they're more cared for in many situations, and decreased overall cost. So, direct primary care. One thing to look about, and there's a quote that in many meetings that I've been to is kicked around, and it says, if you've seen one DPC, then you've seen one DPC. And the nice thing about that is that a direct primary care office, the way it's constructed, can be any way that you want to make it. There are some certain types of modems that we stick to, and those were the 3. We want to increase patient quality, obviously, we want satisfaction, and we want decreased cost. There's many different ways to get through with that. And one of the nice things is when we talk to other direct primary care physicians, their one goal is for the patient. They want to make that care available for the patient. That's the one thing that goes through everything. But how they do that, all the peripherals on the end of that, it's what you want to make it. It's how you want to practice, the hours you want to practice, the price set that you want to do. That's all up to you. So if one DPC, you've seen one DPC. The other thing is a direct relationship and system between the physician and the patient. One thing that the insurance industry has done is that it's created a distance between physician and patient because it's been more complex. In order for us to complete the transaction between a patient and a physician, we have to go through more steps, and those steps are pulled away from patient care. If you think about your office visit today in a fee-for-service model, many times that office visit has turned into nothing more than a way to get paid. I have to see you in my office in order for me to get reimbursed. I have to create a document in order to qualify for that care, and all of that documentation pulls away from a direct patient care contact. So when we have a direct relationship between physician and patient, that has always made such a tremendous difference that we don't have that insurance sitting in front of us. So when I look at the patient's eyes, I don't have that insurance product that sits there and is able to block my transaction with them as well as my communication with them. So I've eliminated that barrier, and the patient feels more that I have their back, that it's a direct relationship, and that direct primary care is a good term because it is directly with me. Many times those direct communications come directly to me. It comes directly to my cell phone, comes directly to my phone, comes directly to my office. There's no algorithm that they need to follow in order to get a hold of me. The other thing is that it eliminates the complexity and the expense of insurance billing. So when you look at a direct primary care office, you're going to see it's very streamlined, it's very efficient, because we don't have to go through the coding procedures that are inundated with our fee-for-service offices. We don't have to go ahead and follow an ICD-9 or ICD-10 qualifications because basically this is a monthly membership type of product. So since we don't have that complexity, it makes our visits very simplistic from the standpoint of just concentrating on patient care. I don't have to have the notation that was required to be reimbursed, and I don't have to have the software systems built in to be able to bill third-party payers. So that keeps the cost down for us as well. It allows an increased amount of time and patient contact without the need for extensive documentation. One of my patients made the comment that one of the reasons that they came to our practice was because I didn't spend my time looking at a computer screen, and they had been to practices where all the physician was more like a scribe, typing down, filling out, checking off boxes, making little circles turn from red to green in order to qualify a certain amount of notation to qualify for that visit. They didn't feel that the doctor was really listening to them because they didn't have that eyeball contact. Many times now I can put that off to the side, concentrate on them, and it's a much better dynamic relationship that we have. The other thing for direct primary care is the physician works for the patient rather than working for the insurance industry. And I've asked doctors in meetings and just in local conversation, do you feel that you work for the insurance company? They said, no, I'm an independent physician. I don't work for anybody. I said, all right, can you see a patient outside of your office? Well, no, I can't do that. Why? Well, I won't get reimbursed because the only way I'll get reimbursed is by working in my office. So you are working for the insurance company because the insurance company is dictating to you how you get reimbursed. That's the control that has. And there's ways that you have to do things. There's ways that you have to make your notes. There's ways that you have to have an encounter with a patient. And there's things that you can't do because you won't get reimbursed for those in certain ways. And you certainly can't bill beyond that level. So yeah, you are. In a way, you are working for the insurance industry. So that becomes a deficit for the physician in many ways because it blocks that creativity and the kind of liberal things that we want to be able to do with patients. The other patient benefits that you're going to see from direct primary care is absolutely limited wait times. We don't even call it a waiting room anymore. It's more of a reception or welcome area that we have because there are no wait times. We've had many patients comment that, are we still open? Because they'll walk into the reception area and there's nobody in there. It's because there's nobody, they're all back. There's only one person back. We'll see a patient every half an hour and it's a nice easy transaction time. They're out by the time the next patient comes back in, so it's very limited wait times. If you ask patients what is one of the biggest reasons they will leave a practice, it's because they had to wait so long. If you ask them what's the hassle of an urgent care or an emergency room, it's wait times. It really comes to a big issue, and in a doctor's office it's been a problem. The other patient benefit is improved access to care. Now, access becomes an extremely big word when you're talking about direct primary care today. It's one of the big terms that we use because we want patients to have that access. Easy access, really timely access. And it's not only access to us, because I can control that. I can control how accessible I am. If I'm not going to be accessible, I can also have alternative ways of alternate coverage or different ways that I can make that accessibility do for the patient. But what do I do about other ancillary services like labs, medications, and scannings, imaging? Because if I can't provide that or help provide that, then that patient's going to be blocked access to that type of health care as well because they can't afford it. So through direct primary care, we're able to facilitate a lot more accessibility to other agencies, labs, meds, imaging, that is going to provide more of a comprehensive care. There's also increased office visit time. Each of our patients gets a half an hour visit. Most direct primary care offices will allow about a minimum of a half an hour visit. The patient doesn't need that. If it's a quick visit, we still can have that face-to-face encounter talking about other things, making new health goals, but we want to make that's their time. And not many practices, especially fee-for-service, would be able to afford to be able to see somebody for a half an hour. In our office, we see about 10 to 12 patients a day would be a full day. Other offices that we've talked to other physicians, sometimes 5 to 6 would be a full day. So again, it's that increased office time that you'll be able to spend with the patient. We have access, as I had mentioned, to discount services and complementary procedures. Because we don't bill for insurances, we do have access to what's called direct client billing, where with lab work, for instance, a lab test, as an example, for a lipid profile would be $92 if billed to the insurance company. But if it goes through me as a direct client billing, that lab test for the patient is around $8. Huge discounts. PSAs would be for the insurance industry $120. For us, it would be $12. And what happens with that, and the way that would work, is that if I'm a patient and the doctor writes me a slip and gives it to me for a PSA, for instance, and I go out to the lab and I give that lab slip to the lab and I said, I'd like my PSA done. The lab says, okay, sign this waiver to realize if your insurance doesn't cover it, you're going to be responsible for this. I understand that. The lab does that. They bill $120 to the insurance company. The insurance company says, we're not paying it because 1, deductible hasn't been met, 2, it hasn't been a year since the last PSA, or 3, it just wasn't enough time, or we're just not going to prove it all together, we weren't going to pay for it to begin with. That patient is responsible for that $120 bill. Might go toward their deductible, but still they're responsible for that allotted amount. The second scenario is through me. If you know you're going to have a problem with this insurance, then let's do this. Let's do direct client billing. The way that's going to work is that I will actually receive the bill for your lab and I will just pass that on to you. What's the advantage? That bill now becomes $12. $12 out of pocket. So we are improving access because that PSA of $120 might not be accessible. $12 is definitely accessible. We also do complementary procedures. So the complementary procedures for us, EKG, urinalysis, different office procedures such as joint injections or freezing, cryotherapies, are just included in the membership model because these items are very, very low-cost items. And to us to be able to extend that out to patients just improves the value that we can offer for a membership model. Medications is another thing for discount services that we can do. You know, I never looked at the cost of medications because for me as a fee-for-service office, it initially is, my responsibility is prescribing the medication, not filling these medicines. But you know, with the cost of medicines, as we've all recognized, that's a blocked access. If I have a medicine that's going to cost me $200 or $300 a month, I may not be able to afford that. I can't get that medicine. So what I discovered, and through the help of other direct primary care physicians, is when I really looked at how much these meds are costing, the cost savings were significant. One example was we have a patient that was taking a cholesterol medication, statin medication. I said, how much are you paying for your medicine? He said, well, I got a pretty good deal. He said, I'm paying $10 a month. I said, that is pretty good. He said, my insurance allows me $10 for generics. I said, how much does that insurance cost for you? He said, well, what do you mean? I said, well, how much are you paying per month? He said, well, I pay $50 a month for a pharmacy plan. I said, all right, so your med's costing you $60 a month. He said, no, it's $10 a month. I said, no, you're paying $60 because you're paying $50 to get the privilege of buying it for $10. He says, yeah, but it's only $20 for trade name drugs. I said, what trade name drug are you using? None. Okay, so you're $10 for your generic, $60. He says, yeah, but that's still a good deal. I said, let me show you. Your medicine, I can get that same medicine for you for $1 a month. So here's the scenario. You are paying $50 to the insurance industry for the privilege of buying a $1 medicine and paying $10 for it. Does that make sense to you? No, it doesn't. So he dropped that part of his insurance. The $50 came back into his pocket. The $10 came back into his pocket. And through one encounter, we saved him $60 a month. That through most plans is the cost of a membership model. So just by those inherent value, you've actually washed out the cost of direct primary care. There's no benefit to us. We get the medicines at cost and pass them at cost with no price increase for that. We're not making money off the medications because we want that to be an unbiased intervention for that patient. They know the reason we're doing this is because it's for their betterment. So those are some just complementary and discounted procedures that we can do. What's the provider benefit? You know, what's in it for me, right? What's in it for me as a physician? Well, one, and we had mentioned this, is the satisfaction of patient care returns to you. One of our mottos in my office is rediscovering traditional medicine with today's technologies. I can do virtual visits, I can do text messaging, I can do email that makes me infinitely more accessible to patients than older type communications. But it's that rediscovering that traditional role of me being there for the patient. But the other provider benefits, under a direct primary care model of a monthly membership fee, you do have a consistent income. It's not based off of how many people can I fit in my office per day. If I see one person or I see 12 people a day, it's the same level of income. So that's a very consistent deal. If I take care of someone through email, even though when I'm not in that office, or whether I'm in the office, it's the same level. Think about it with a fee-for-service model. When I was a fee-for-service physician for 25 and a half years, if I went on vacation and left that office, that was a double whammy for me. Because not only did I take a hit because I wasn't generating that income, but I had to pay for the vacation. So a vacation was never a vacation for me. So the consistent income is a nice benefit of doing this model. The other thing is limited outside control. Because we don't deal with the insurance companies directly, we don't have to confine ourselves to office-based medicine. We can do home visits without having to worry about making a modifier on a charge, because there is no charge for that. And for limited outside control, we can do many more things the way we talk to patients and we convey our information to them. The other thing is there's more time dedicated to patient care. The patient benefits from that, we benefit from that. I'm a family physician that I enjoy that contact. I really enjoy it. I think it provides better care. I think the relationship idea of family medicine is why I got into family medicine. I really enjoy getting to know my patients and know what makes them tick. And I think it makes me a better physician because I know and I can sense when they're out of sync, when they're not what I was used to seeing, I'm more persistent. It's almost like a mother that knows their child so well that when it's just that little bit out of sync, she's the one that's able to detect that. So that art of medicine where you just feel there's just something not right and a gut feeling that I need to pursue that much further is something that comes valuable, but it's only spent with time with the patient. There's also limited overhead distractions. Most medical billing systems that we have for direct primary care are automatic. It's an automatic withdrawal from a credit card, an automatic ACH transfer. We get a statement, but we don't have to mail out individual invoices. We don't have to go through billing protocols. We don't have to do through EOBs and explanation of benefits through insurance industry. It's a set deal. It's an automatic. So that's one overhead distraction you don't have. You have a smaller staff. Most direct primary care offices are existing with 1.5 full-time equivalent employees, maybe a nurse, a part-time receptionist, because most of this care can be done without the confines of the office, and obviously you've eliminated your entire billing team because it's an automatic process. The other thing is it truly is a limitless potential for growth. And if you think about it, you want to be able to grow to a point that you want to still be able to provide those services. So you don't want to go beyond that level, which is generally about 400 to 600 patients, but you want to be able to get to a point where you can be financially viable, which is about 400 patients. Beyond that, you can grow your practice by adding on either mid-level providers, nurse practitioners, physician assistants, or provide a job for a physician. Right now in the United States, the average is one doctor per 2,500 individuals in a full-function fee-for-service office. In our model, we have one doctor per 600 patients. So if you took that same 2,500 patients that had the one doctor, now we'd be able to employ 4 physicians for the same group of people that are looking over 600. So we've solved a problem with the increasing patient care demand and decreasing primary care physicians, that we can provide more opportunities for primary care physicians, which is very exciting from the growth of medical students and residents, that there's going to be more jobs available and very good paying jobs as soon as you step out of the residency program. So what are the questions you need to ask? If you're starting your own DPC office, if you're converting your office from a traditional fee-for-service, what are the things that you want to get through with direct primary care you want to ask yourself? Well, I think first you have to ask, is this for you? I mean, is this the type of medicine you want to practice? Because you are a limited population, you're going to see less people. If you like a very hectic pace, maybe this isn't for you. But you're going to tone it down, you're going to spend more quality time with the patients. If that's what you want and the value of that, then this is the place for you. You need to know in your state what laws are in place. There's many good resources, and we have resources on many different websites that we can make available, that you need to know your states. Every state has different type of DPC laws. Right now, as I understand, there's 13 states that have actually passed DPC legislation. The others are kind of left in the wind. You don't want to do anything that's going to close you down or cause any type of insurance commission or problems with that. So you need to know what laws are in place, and like I said, I really recommend that you do get some legal counsel to try to figure out what forms. Contact other DPC physicians in your state. Hey, what did you do? I've never been turned down by another DPC physician for advice. It's an abundance of advice, so utilize that. Question you want to ask too is, do I want to do a hybrid or do I want a full DPC? Now, a hybrid practice is where you keep part of your fee-for-service patients, you still bill them, you bill their insurances, and maybe the other part you keep as a direct primary care where they do a monthly membership. A lot of practices will do that just starting off because they say, well, I really want to be secure about this one source of income because I'm used to doing that, and I'm going to try this out on the other end. There's pros and cons to each. The con is that you've kind of kept your problems you're trying to eliminate because you still have these billing systems, and it gets confusing for the practice. The positive is you will restore more of your income when you're first starting out. Full DPC, you just start right off the bat with saying this is what I'm offering, it's a monthly membership, and it's a growth potential from there. Am I allowed to dispense medication? When we dispense medications, and the example I gave to you, it's a very big enticement for someone to come into a direct primary care office. There are certain states that do not allow or have very restrictive practices on the way you can dispense medication. Once again, that's something that you can find online, find through resources, know your state, know what you need to do, take the provisions to be able to provide that or work around that. Can I direct client bill for labs? That's what I was making example to for the lipid profile of the PSA. Can I do that? And you make relationships with local labs, private lab companies, And it's as easy as going to them saying, this is what I'm going to do, and I want to have a cash pay alternative for my patients. What kind of discounts can you give me for these services? We have these prices listed. We have the people that you can talk to through the different lab companies that are available. I ask you, please contact us through email or through text messaging or through our websites. We'll be more than happy to be able to help you out and point you in the right direction. The other questions you need to ask: do I have to reduce the staff? Now, for those starting out, just starting your practices, then you need to be very selective about who you need to hire. You don't need a big staff. If you're converting a present practice, then you have to reduce your staff because you don't need as many people. So it's a question you need to ask, and whether going forward, is that something you want to do? What software can I use? Well, you know, medical software years ago was extremely expensive, almost cost prohibitive. With the passage of the Affordable Care Act, almost made it mandatory that you needed some type of electronic medical record. The prices came down, but also the amount of vendors into the market really shot up. So my best advice to you is look for demos. Almost every software company that I've seen will offer you some type of demo. You get something actually related to direct primary care, and there are direct primary care software available. Do a Google search for that, see what pops up, try them out. Once again, contact other DPC physicians. What's working for you? Most of these companies will say, try it. You know, you'll like it, you're good. If not, you know, tell us how we can improve it. So that's not a big problem to have, and you just need to pick what's going to work for you. If you're converting a private practice, like I did, you want to know the percentage of patients that will convert over to your direct primary care model. What I've seen and what I've asked other physicians around, it seems like it's about 10% of your population will come over for you. So for us, we had 3,800 to 4,000 patients, and we had about 380 to 400 that came over with us right from the get-go or over the first 4 to 5 months. And the rest we've grown from just those patients talking to their friends and had people coming over from there. Financing. When you start your practice up, like anything, you're going to need some startup costs. There's a lot of ways to go through the startup cost. You can go through startup costs as far as just getting a loan. Sometimes when that's hard to do, moonlighting is always a great opportunity. Maybe you have some cash reserves. Maybe you have a family friend that can loan you some money. You want to try to keep your costs down. There's different alternatives that you can do that, but make sure you're not going to start off with a profit right off the bat. You're going to need some financing for that. We do talk about moonlighting. When I was in residency years ago, I couldn't wait to moonlight, and I was a moonlighting crazy person. I worked in a jail, I worked at a harness racing track, I was an air ambulance physician, I worked in the emergency room. And now, as I've even converted my practice, after these many years, now I'm moonlighting in an urgent care. And it's a wonderful place for me to be able to spread the word of direct primary care, because I'm wondering, why are you in here rather than talking to your family physician? The urgent care has, I think, a great place in our society. I think it really serves a purpose to keep those people out of the emergency room, which is more expensive care, and to serve those people that are having trouble getting in to see their family doctors. But it helps because I can do this and I can help pay our bills as we do through the transaction. So moonlighting is a great source for meeting patients and also just making that extra income. How do I market and advertise this? Well, I tell you, you could probably spend hours and hours and hours on what's the best way to market. I think what comes out, word of mouth, is still the easiest, the least expensive, and the best. You provide good services, it's going to spread. You want to make yourself visible. You want people to know you. You want to be transparent. You want to talk to local businesses. You want to talk to your Chamber of Commerce. You want to get involved in the community. You don't have to spend money for this. What we did was one of the best things that we did. We got the local news station to cover us. We told them we were providing a very unique product for healthcare. They came in and covered us. We had phone calls, and people sign up directly from that television story. We posted it on our website so people could re-look at that. I had one of my patients that was able to make a comment about how they liked the services and why did they choose that. It was very, very, very powerful, and it was no cost to us. We tried other ventures, newspaper ads, which did not work out very well. And yet I think how many people read newspapers today. Facebook was always something that we were able to do, and the digital media was always something you're able to put in. Depends on how good you are on Facebook and how much time you want to spend doing that. Some people really like it, some people don't. So again, it's customizable. What do you want to do? But the most important thing is that when you have that person right in front of you, that's the biggest marketing tool, because you're going to market because of the quality of your goods. And people will tell people that, hey, you got to check them out. Problem comes in, patient says, I went to call my family doctor, I couldn't get in for 3 weeks. Oh yeah, I called Called my doc at noon. He had me over there at 12:30. I was in and out. Got my medicines there at basically $2 because I just had an upper respiratory infection. I didn't even have to go in. I really just went in just to go pick up the meds. Really? Yeah. Man, can I get your, sure, give him a call. I mean, he's looking for more patients. That's the type of thing we want to be able to hear. So in essence, what I want you to really understand about a direct primary care option is it really is rediscovering what it was to be a family physician. For those of you just starting out, you don't even have that perception yet. I had that perception. When I came out, it was what I wanted. And I saw over those years how it was changed and how disenchanted I was through no fault of my own, that I saw this thing occurring that was, I was losing what it was to be a family physician. And I could see that I couldn't give the care that I wanted to give. And I started looking for alternatives. And this has been an 8-year process for me of thinking about what I want, but then making it happen over the past year and a half or so. And I've come to this point now where it's the best move I've made as far as restoring what used to be. I'm saddened that it had to come to this. My original role of being able to primary care physician was that at this point in my life, I was going to be kind of just practicing because I wanted to rather than I had to financially. But factors beyond my control took over, and that's what happened. And through this market, you look at sometimes the bad things that can happen in society will ring in something that's even better than it was before. And I do believe that direct primary care is going to restore what it was to be a family physician to a level that hasn't been there for decades. And so I applaud you for thinking about direct primary care and really encourage you to look at this as a huge, huge viable option for continuing primary care. Thank you.